So thank you all for coming to a CFAR-sponsored lecture that's part of the core. I think this is part of the biobehavioral new and substance use core. I think this is our first inaugural talk. We are really delighted to have a speaker, Eli Rosenberg, who comes to us via Emory University in Atlanta, Georgia. Eli Rosenberg is an epidemiologist, a card-carrying epidemiologist, both in terms of his training and in terms of his departmental affiliation right now at Emory. So he's a faculty member in the PRISM group, which is part of the Department of Epidemiology, and the Center for AIDS Research at Emory. So he manages a diverse portfolio of HIV and other diseases and studies supported by the NIH and CDC. And he oversees many of PRISM's data management, data analysis, and data scientific dissemination activities. His interests are in epidemiological methods and analyses for understanding pertinent issues of HIV surveillance and prevention. And he is also a guest researcher for the CDC's Division of HIV Prevention's Behavioral and Clinical Surveillance Branch. So one of the other things about Eli is he's also funded by NIDA as co-PI of a cohort of young black MSM looking at substance use and acquisition of HIV and PrEP. And I have to just tell a little side story that's a positive one about Eli, that this is an example of wonderful networking. And if folks are at all familiar with the CFAR SBRN program, which stands for Socio-Behavioral Research
Network. Science Research Network, SBS.
Anyway, it's something that's supported by the CFAR to promote scientific collaboration in socio-behavioral sciences. And Eli and I met at one of those meetings about 8 years ago or something. And I think I was talking about doing some work on partnership-based research in HIV, and Eli was also interested in this. And this just shows you we ended up sharing ideas and actually sharing instruments and questionnaires. And he has used some of the things that I developed in his work, and together we're now writing papers together based on that. And so it shows that at these meetings, sometimes you hear stuff people are working on, and it's really worth talking to them and networking them. And now, we can do some interesting comparisons maybe between the work that he's doing in Atlanta and the work that we're doing in Los Angeles here with young MSM as well. So it's a good story too of positive collaboration on his part for also reaching back to somebody. He was a little doctoral student, and he grew up to be this wonderful faculty member, all independently funded. So anyway, it's a great pleasure to bring him here to share the really exciting work that they're doing at Emory. And I think you all remember Patrick Sullivan was here as our guest a couple months ago, and Eli and Patrick Sullivan work in the same group.
Yep.
Right?
Oh yeah,
a lot of the same studies.
No, we.
Buds.
Yeah.
Okay, so
totally.
And
Great.
one more thing.
Yep.
Before I forget, Eli will also be giving a 2 o'clock more in-depth sort of seminar that was going to be looking at methods and more in-depth focus on the work he actually does. So if you want to stay or come back here at 2 and get more Eli, you're welcome to join us as well.
Great. Thanks. Okay, so today's going to be a lot of data, and I'm going to try to get through it all, but also not get through it thoughtfully. So, and hopefully we'll have some time to talk at the end. I come from Emory with all sorts of logos and so forth, but really I'd say my most proximal affiliations with the PRISM Health Group, and I'll show you all of our pictures in a moment. And today we're going to talk about the racial disparities in HIV infection and among men of sex with men. I'll mostly be focusing on Atlanta, though not all of our work is really restricted to Atlanta, but that's where we've done the most work. And so I'm just going to go over just a quick tour of really the big picture epi situation for HIV infection for MSM in the United States. And I want to kind of put forth a kind of a causal framework for the epi folks. It will be a DAG, it will be all epi method Z, but and I'm gonna hang some data on it. And I'm gonna kind of go through really 3 pathways of risk, differential HIV risk for black MSM. And then I'm gonna show some modeling work to kind of synthesize a lot of our empirical findings and show some cool modeling results. And then I'm gonna kind of end on really where do we go from here, how do we fix this? Because we're really in quite a situation in the US Southeast. This is us at Prism Health. We're 8 faculty members. Some of these folks you might have met before in various other places. We're at the top. This is maybe the original 4 investigators of us, and who started a lot of the studies that I'm going to be showing you in a few moments. And Prism Health is, I'd say, sort of founded / spiritually managed by Patrick Sullivan, who a lot of you folks met, and he was my dissertation advisor, and we really together launched some of these projects. So this, in a sense, was a fun talk to prepare, because this subtitle is kind of like, or what Eli's been doing for the last 8 years without sleeping. So this is kind of just really what we've been doing for a while, assembled into one talk. So I'm going to run through the overview of HIV infection for MSM in the United States. For people that, how many people here work work with men who have sex with men in HIV? Okay, so all right, so I'll be preaching to the choir. So some of these pictures and overview will be old news, but I wanted to just bring everyone up to speed. So I'm sorry if this is just data you've seen 100 times. In one snapshot, the HIV epidemic in the United States approximately affects 1.2 million people, depending how you count it. CDC's 2012 estimate was about 1.2 million individuals, ranging from 40 to 50,000 new infections per year. What's the number exactly? Nobody knows. CDC stopped counting. I have a love-hate relationship with CDC, so if you just bear with me here. I do a lot of work with them, but I like to tease them a lot. And working with the federal government's always fun. And as you know, we characterize typically the HIV epidemic in the US by risk group, with the 3 primary risk groups of interest being men who have sex with men, injection drug users, as well as high-risk heterosexuals, and then other key issues, such key groups, sex, age, race, region. And we also know that the majority of new infections are occurring among men who have sex with men. So this is a slightly outdated graph, I suppose, but CDC hasn't put this out past 2010. But in 2009, about 61% of new HIV infections were among men who have sex with men. And we also know that among men who have sex with men, Black and Hispanic MSM are disproportionately represented. This graph on the right here is the number of new infections among MSM. And we see here that Black MSM have accounted for almost as many new infections as white MSM, despite being a fraction of the population size. And we see that among Black MSM, the 13 to 29 age group is over half of those infections. Compare that to the situation among whites and Hispanics. So we have clearly some very different racial patterns within MSM that are important. So this is a map of the United States, and this is the rate of new diagnoses per 100. We've actually been doing a lot of work sort of in conjunction with CDC to be able to get denominator data for MSM in every US county and state. And so this is a map that no one's seen before, except for you guys, so this is pretty cool. And really, this is the rate of new diagnoses, so something sort of like incidence, but it's new diagnoses rather than infections. And when we see here that the US Southeast is really the area where the growth of the epidemic is highest. And so we're situated up here in the top left corner of Georgia. But really, the deep southern states and really the South in general is the area where we see the highest levels of new infection. And this is the same map for prevalence of living with an HIV diagnosis. And we see here that prevalence has gotten quite high in the U.S. Southeast. We're talking 18% in Georgia. Mississippi is about 23%. So HIV prevalence has really mounted to quite crazy levels in the US South. And we're going to kind of be unpacking some of that today, because a lot of it is question already. Yes?
I didn't know if you were ready to take a question. Can you ask, I have a quick question about the last one?
Absolutely.
I'm curious how far above 1%. I'm actually surprised this only goes to 1% per year.
Yeah, so the new diagnosis, so you can express new diagnoses in several interesting ways. This is the most naive way. This is over total MSM. There are so many men living already with HIV in the US Southeast that you actually have to subtract them out of the denominator to do the rate of new diagnoses per undiagnosed, and then the rates climbed about 4% in some areas. So this is over total, and we did that to align with other metrics. So CDC normally does over total males, not uninfected males or undiagnosed males. So this is, I got a whole lot of other pictures I could show you that does it all those ways. So this is just to show that we really have a lot of concentration of infection in the South. Here is a county level map zooming in to where we're situated here in Atlanta, where the counties that comprise Atlanta have HIV prevalence basically north of 20% among MSM. And you can see there's actually counties where we have 30% or higher prevalence. So yeah, this has been my last month is really, we've been generating, sorry about the flickering, some very detailed looks at prevalence. Atlanta and Georgia are a particularly interesting setting out of all the southern states. We have the highest population really out of many of these states, and in particular, Atlanta is the largest city for quite some hundreds of miles in every direction. And so we're really at this confluence of high population, high prevalence, a higher density of MSM per capita because we're essentially a destination city for men who have sex with men, and a very high proportion of those MSM are minority. And so we're really at a very, very unique epidemic in the South and really in Atlanta. These are some data from the cohort study that I'll be showing a lot of results from today. This is our involvement study, and we had enrolled 803 men who have sex with men, and this is cross sections by age and race of HIV prevalence. And what we see here is that really our overall HIV prevalence is frankly quite similar to what we did with the surveillance data. We see about 30% prevalence in this sample. And this was venue-based sampling, so I would expect it to be a little higher than a general census-based view, which is what I was just showing in the maps. And what we see here is that by the mid-20s and beyond, HIV prevalence has reached very, very high levels among black men who have sex with men in Atlanta. This is frankly, this was alarming to us, but this is old news for people who've been following NHBS data from the National HIV Behavioral Surveillance System. But no one had really done it at this level of detail within a southern city before. And so we see here we really have two very, very different epidemics for white and black men who have sex with men in Atlanta. And really, so the overall prevalence was 44% versus 13%. And I'm going to try to figure out why, or we're going to try to work through some of the pieces of why this is going on today. So, and really notice here that most of the risk is accrued by the mid-20s. I think that's really an important finding here, that really by the time we're looking at the late 20s, we're talking 45% prevalence in men who have sex with men. Here's actually in that same study, we actually also measured incidence. That was the involvement study. I'll go over the design a little bit more, but we followed men for approximately 2 years. And these are cumulative incidence graphs. And basically, this top group here, this is our these are our youngest men, 18 to 25 years old, and we measured 11% incidence in that group. Which really stands out, frankly, from the other groups here. Obviously, we have 3.6% among annual incidence rate among black men who have sex with men above 25, and then white men were between 1 and 2% incidence. And the overall rate was about 6% when you collapse age for black men who have sex with men. And I was talking with Steve last night, and that's frankly very similar to what HPTN 061, the Brothers study, found for LA and also for Atlanta as well. But really, it's really just like we saw in the prevalence graph, the incidence is showing this real difference between those below 25 and those above 25. And that really by the late 20s, we've missed some of the period of highest risk for black men in Atlanta. So this is an unproductive view of the epi. This just came out last week for people who was anyone at Croy last week? Anyone see this come out of Croy? This is part of my love-hate relationship with CDC. I think incidence is a very helpful, epidemiologically sound way to view the risk that accrues to men. CDC presented on a lifetime risk of diagnosis model, which is what I call an extrapolation model, because they extrapolated from present day diagnosis rates across lifetimes, it came up with some very shocking statistics that made for some really horrible news stories, such as HIV risk soars, half of all gay and bisexual black men will be diagnosed with AIDS, which is like totally out of a hat, crazy. And this, we could talk more about this, but this is an example of how to not to do the epi well. Even though CDC presented on some very good work at CROI, this, the way this was, the messaging for this was handled was very upsetting. So if don't make infographics like this, please. So the HIV epidemic among men of sex with men, black men of sex with men in the South has really kind of been recognized as a national priority. For those who have read the National HIV/AIDS Strategy, the NHAS, goal 1 is reducing new infections basically among these groups. So, and they highlight black MSM, the South, and so forth. So this is the situation in which we're operating at Emory, is an area of very, very high concentration epidemic, very high incidence, and high priority, high national priority. So I'm just going to walk through some of the pieces that have been hypothesized to be causing this. So Greg Millett, formerly of CDC, then of the White House, and now of AMFAR, has really published a lot of great papers that really synthesize the available evidence for why black men compared to non-black, and in many cases when I'm talking non-black, I'll really be talking about white, non-Hispanic men of sex with men. He's really kind of collated the data in several key publications to try to understand what's going on here. And this is a huge graph. There's a lot going on here, and I'll step through pieces of it. We're not going to go over everything. This is the relative odds of having a factor for black men versus white men. So everything to the right would be something that black men of sex with men report more than white men. Everything to the left of one here is things that are less common among black men relative to white men. And I'm going to kind of put things into categories and then talk about them as categories. The first thing here is that everything that's yellow is what we typically have often thought of as individual level risk behaviors, such receptive, unprotected sex, injection drug use, and so forth. And this has really been the narrative in the literature for the last 15 years, that black men actually seem to have lower levels of what we classically consider high-risk activities compared to white men. And that's kind of all these factors over here. There's some interesting pieces that relate to the demographics of one's partners. So here's having black partners. Black men are most likely to have black partners, maybe some evidence for older partners, and then here's same-race partners, which is a similar idea. A lot of the factors that were assembled in this review here have to do with inadequate suppression of HIV infection. So we're talking about or just issues of HIV infection. So here, less access to ART, less adherence, low CD4 count, having an undiagnosed HIV infection, issues, frankly, of uncontrolled HIV or not well-regulated managed HIV. I'm going to put a box around these two things. I'm going to call them partner issues. If I'm living without HIV, these issues that are more common among black men of sex with men don't directly pertain to me other than they affect my community and the men I have sex with. And so these issues are important, but I'm going to call them partner issues because from the perspective of someone at risk for HIV, these are partner issues. And then there's a few what I call social or cultural issues, larger scale social determinants, which are clearly in the background of all of this. Education, income, incarceration, and so forth. So we're going to put those into a category. I'm going somewhere here. We're making another picture out of this. I'm just trying to synthesize all of this into a smaller model. And then I'm going to just say biological cofactors here, which I'm going to put as an STI diagnosis. And we're going to address kind of the co-occurring STI epidemics later. So I'm going to propose a simple causal model here for talking about this. How do we get from race to risk for men of sex with men? How is it that race is actually a cause of disparate HIV infection? In a sense, that doesn't make any sense. There has to be some pathway here by which we get from race ethnicity down to HIV risk. And I see it really as acquiring HIV really has to be the sum of three things. You have to conduct some behavior to put oneself at risk, which I'm going to call individual level risk behaviors. You have to encounter a partner who is capable of transmitting HIV to you, and then I'm going to also put another bucket here, which I'm going to say biological cofactors. But basically, you have to be susceptible to HIV, and there's factors that may increase or decrease your susceptibility. But really, HIV acquisition is the sum of these three parts. Engaging in behavior and counting a partner who can actually transmit infection and being at risk. And so if you look at the Millett work, you can kind of essentially put it into, this is at least the way I have organized pieces here. How do we get from race ethnicity down to individual risk? And from the Millett work, it seems that this arrow here does not exist. There's no association between race ethnicity really and individual level risk behaviors. And you can sort of take them out in a sense, right? I'm blazing through this graph quickly because I'm trying to get to some more results, so I'm sorry, and we can come back to this. But basically, according to all of the body of the literature, the race ethnicity is not particularly associated with elevated individual level risk behaviors, and therefore there's really no way to get to this box. And therefore, a lot of what must be going on would either have to be operating through these two other boxes, and I think probably quite a bit is going on through the community, and we'll talk about HIV care in the community particularly. But really, a lot of the social forces and other forces must be operating really on the partner and the network level, because we don't see any empirical evidence of differences in risk behaviors by race. And we'll talk a little bit about the possibility of there being some biological issues that are different by race as well. So here at Emory, or there at Emory, I suppose, we have a number of studies, past and present, that have really dealt with issues with the MSM HIV disparities. I'm going to really be talking mostly about in the involvement study and some from the MAN project here, which both concluded within the last few years. These bottom three are kind of our current generation of projects, and I'll talk maybe slightly at the end about them. And I'm also going to talk about the MARDM project, which was a modeling study that really synthesized a lot of our earlier work. So we've been busy with all these projects. So the involvement study was a prospective cohort study looking at HIV and STI incidence in Atlanta among black and white men of sex with men. And basically we recruited the study about 50-50, more or less. It was the entire purpose of which was to compare for differential reasons for acquisition of HIV and STIs. So the entire design was around understanding disparities, and we recruited a 2-arm study just for that purpose. And we looked at sexually active men between 18 and 40. We recruited using venue time-space sampling and with some recruitment from Facebook, but it was about 90% through venue time-space sampling. Men came in on this schedule. During their follow-up period, we had testing for HIV and rectal and urethral gonorrhea and chlamydia and syphilis at every visit. We had a pretty extensive behavioral questionnaire at every visit as well. And in the workshop today, I'll talk a little bit more about the questionnaire because I think it's fun. So we enrolled 803 men. This was the prevalence data that I showed earlier. And so the prospective set of men, those who are not living with HIV, was 562 men who were then observed over the 24-month follow-up period. And our 2-year retention was about 80%. And there were essentially no differences in retention between the two study arms. So what was cool about the involvement study, just to situate it, at the time, and I think it's still the case, it was the only study really designed around incidence disparities for black MSM, and so it was cool. We actually had a 2-group study, but we can really just entirely focus on that issue. Usually this is the race disparities are often secondary inside of another project. We collected data on a whole bunch of different levels, so at individual level behaviors, very extensive partnership data collections, as well as some neighborhood-based analyses that we did. And we really were able to go very deep into Atlanta and in studying a single place, which is different perhaps from the 061 study, which was going on at the same time, ended a little bit before our project did, which was in six studies? I think 6 studies. Yeah. Which was, so we had fewer Atlanta, we had maybe 100 or 150 Atlanta enrollees. We did the opposite approach, which is go more men in a single city. And we also had the white comparison group. But 061 was not about studying disparities per se. It had some other objectives as well. So I'm going to, just jump through this here again. We already saw this. I'm going to revisit this with our involvement data in a moment. I'm going to show you how we essentially evaluated this meta-analytic, we took this meta-analytic approach that Greg Millett laid out, and we essentially measured most of these within our own cohort, and we're able to evaluate the extent to which these factors explain the race disparity in our cohort, and that's what I'm going to show you in a moment. The Millett work, each of these are meta-analytic results from across the entire literature. But what we were able to do with the involvement study was actually measure all of these in-house in one study and evaluate them on incidence. So I think that was pretty neat, and I'll show you what that looks like here. So this is the incidence graph that I showed before, and what we try to do is take this incidence, take that framework for all these factors, and try to see what explained the disparity. And we did that with a mediation analysis. So with a mediation analysis, we're trying to basically block, if you imagine that there's a race disparity, it was about a 3-fold adjusted hazard ratio for black versus white men in our study. And we wanted to basically control for factors and reduce the observed disparity through statistical control in a Cox proportional hazards model. And so in this graph, the idea here is we're trying to move our hazard ratios left to 1, and that in theory would be explaining away some of the incidence disparity that we observed in the model. So anything in this green zone, this is a more than 10% reduction in the hazard ratio, which we just said would be a meaningful reduction in our disparate HIV incidence. And what you see here, honestly, is very similar to what the Millett work showed, which is not very much seems to be able to explain the disparity, even though we measured all sorts of things: social determinants, individual behaviors, some partner issues, some neighborhood issues. And very, very little stands out, which is remarkably frustrating. A few things do stand out. Health insurance was actually, controlling for health insurance seemed to be able to reduce the disparity somewhat here, as well as neighborhood level income. So we had a few social determinant, big picture pieces that seemed to mediate incidence disparities. But what really seems to matter is partner race, which is the most challenging piece of this here. So it seemed to be that once we control for the men that people have sex with, that the actual race of individual respondents essentially became non-significant in the model. So we're going to have to talk about, well, what does that mean? It's not your race, it's your partner's race. What does that mean? And we'll show some more results, but essentially it's pointing to this intuition earlier that men are not necessarily engaging in different individual level risk behaviors, but there's some aspect of the community at large that's disadvantaged in terms of HIV infection. And once you control for partner issues, one's individual HIV risk seems to be largely explained. So this was, in a sense, a very surprising and difficult results to work with, but actually made a whole lot of sense to us. So what we got from the main incidence results from the involvement study was that we were able to verify that indeed MSM and black MSM were facing very, very high levels of incidence in Atlanta. We didn't expect incidence to be this high. When the study was initially designed, we were not expecting greater than 10% incidence. So that was very, very shocking. And then it was, just very shocking. We verified that individual behaviors while associated with incidence, did not account for the disparity. So that mediation analysis was what could explain disparities. The individual factors indeed predicted incidence, they just did not explain the disparity, which is, again, this is what we knew from the meta-analytic work, but to actually show it inside of an incidence study was really the novel contribution there. But we found evidence that indeed sexual network factors and social determinants may be more important than those individual risk behaviors as drivers of disparities. And it's really important to recognize that this is still a limited view. We've advanced the conversation a little bit by saying that it's not individual level race, but rather the race of one's partners and their network. That is not a very intellectually satisfying or complete view of what's going on here, and I'll explain how we advance the conversation further than that. But what was an important contribution was to say that we were able to at least abstract out the risk from one's own race and just say, no, we could control for the community, and somehow that is able to eliminate individual level disparity. But that is still, that's essentially kicking the can down the road, and now we have to fix the community issues. So, and we'll talk about that. But, so it's an important contribution, but it's limited. And we'll talk about that. So there's a lot of big questions. I have these now what's at the top of a bunch of slides during the next these two presentations. So what is this? How does the partner pool and network confer risk? How do social forces shape that risk? How do we fix this? How do we intervene to reduce disparities? And maybe what gave rise to this is some important questions. And I'm going to talk about the first one. I'm not going to solve this bottom one. But I think we have a responsibility to go further than that analysis. So I'm going to show just a couple interesting results that really dissect the community level effects in Atlanta. So here is a study from some results from the MAN project, which was our study of sexual networks that went on at the same time as the involvement cohort. And I'm going to digest a lot of information quickly here. These graphs here show prevalence among the partners of seed respondents. We did a referral sampling study. And so for example here, this 36% means that in the partners of men in our study, of the 117 seed partners, in their of 117 participants, 36% of the men in their networks were living with HIV infection. Then we stratified that by the ages of our seed respondents. And we found that in the men 18 to 24, about 27% of their partners were living with HIV infection, 29% in the middle age group here, and then 54% among men ages 30 plus. But the most interesting finding here was that we found that in the youngest men, 18 to 24, who were HIV negative, so HIV negative at Black MSM 18 to 24, they had the highest prevalence of HIV infection in their networks, 9%. Compared to 2% and then 1%. And so what we were able to show is, at least at some level, there's a concentration of HIV in actually the youngest networks, and that we saw the reverse effect here, that as men were older, their networks were more and more comprised of HIV-infected men. And so here we have 30-plus-year-old men living with HIV. We see about 81% of men in their networks were living with HIV infection. So very, very high prevalence. So this is essentially a clustering process where men are living with HIV, choosing partners who are of like status and so forth, is probably what's going on here to give you very, very high prevalences among men living with HIV in their networks. But this also illustrates that there's some mechanism by which young men are being placed at risk here. That we have the highest, and among men who are HIV negative, the highest prevalences in their networks were observed among the youngest men. We don't exactly understand what this means or how this is the case, but it seems that as time goes on, HIV negative men seem to be more likely to have sex with other HIV negative men. But in the youngest groups, either owing to low levels of diagnosis and low level of communication of status, or having HIV status be part of the partnering process, we actually see the highest levels of prevalence. So this actually can potentially explain why we see such large disparities in incidence. If you look at 9 versus 1%, so we have a 9-fold relative likelihood of encountering an HIV-infected partner in the networks of black men by age. So we see that this potentially could be partly why we see the highest incidence in our youngest men. But there's more to it. So We also use data from the MAN project to look at the efficiency of serosorting. So HIV serosorting is this idea that there's some deviation from random mixing by HIV status, that men who are living with HIV would seek out other men who are living with HIV to have sex with, and same with HIV negative men. And it's debatable and probably context specific how protective HIV serosorting is as a risk reduction strategy. But what we were able to do with data from the MAN project, where we basically had this linked network data, is we looked at men's perceptions versus actual statuses of their partners. And what we basically found was that among black MSM who are HIV negative, follow my little tree diagram here. Sorry, it's a little small. So this is black MSM participants who perceived their partner to be negative. They had the highest likelihood of their partners being actually positive. So this is essentially incorrect assumptions about partner status. So that could be due to higher prevalence, lower awareness of status, and less discussion of HIV status before sex, all of which have been shown in this population. If you track that down to the equivalent piece among among men who are white and HIV negative, only 5% of those partners were true. Who thought their partner was HIV negative, only 5% of those partners were actually positive. So we basically see here that these patterns, these network patterns, also when you add on the layer of what men think about their partners, what we get here is a lot of incorrect assumptions about partners' actual statuses. And so we see here that probably in the Atlanta setting, serosorting would have very differential success by race. And unfortunately, you'd have a lot of incorrect assumptions here for black MSM. Notably, a full half of status unknown partners were actually HIV infected in the sample. So 48%. So these sample sizes are small because these studies are really hard to do. You can go to Pamina for therapy about that. But these sexual networks projects don't yield very large sample sizes. So I'm going to add on another layer of complexity, which is that HIV prevalence alone isn't that useful because we need to really be looking at unsuppressed infection to understand what accounts for transmission risk. And I'm going to respect our time here, so I'm going to skip to the next graph. We basically synthesized data on HIV prevalence and viral load in our cohort. I made a very simplistic model here a few years ago to look at, given the observed levels of prevalence and the observed levels of viral suppression in the community, what's the likelihood of actually encountering an unsuppressed partner for black and white men of sex with men? And we also layered in the racial mixing data that we were observing in the study as well. And the moral is that at two unprotected sex partners, our black participants would have had about a twofold likelihood of actually encountering, this is essentially at random, a partner who was both HIV infected and unsuppressed, given all those factors that we just talked about, the prevalence, levels of suppression, and race mixing patterns. And if you're a black man with sex with men in Atlanta, it only takes 3 partners to have a 50% likelihood that one of them is unsuppressed, compared to 7 in Atlanta. And it takes 10 partners to have a 90% chance that one is unsuppressed. So basically, the idea is here at similar levels of risk behavior, just by the sheer epi situation that we're in right now, black men have a much higher chance of encountering an infected partner who is able to transmit HIV. So can we take this even further? So I'm going to show you, you can actually take this to the care continuum itself. And so I'm going to show you can take these principles and you can actually reconstruct the incidence disparities in the US from the HIV care continuum. We know that, so for people that know this framework, the HIV care continuum is usually used to understand care and where attrition from HIV care is in the US. But you can actually use transmission rate information, and through a bunch of ways that we can talk about, but you can basically we know approximately how high transmission is for those who are undiagnosed, retained but not in care, retained in care or not retained in care. We have rates of transmission for those groups, and we can merge the HIV care continuum with that information to look at where in the care continuum transmissions are occurring in the US. And so basically we synthesized a bunch of surveillance reports to reconstruct the HIV care continuum for black men and then for white men in 2009. This is a pretty pessimistic view showing 16% viral suppression for black MSM in the US. This is probably a bit low, and there's just a lot of surveillance issues at play here, but this is actually, if you put the reports together, what it shows, versus 34% viral suppression among white MSM living with HIV. Using available transmission rate data for those who would be living at each stage of the care continuum, you can estimate about the same exact number of HIV transmissions emerging from the black MSM community living with HIV and about as white MSM per year. So about 10,000. This care continuum should result in about 9,800 transmissions compared to 9,710 for white MSM. Notice it's very similar to the graph I showed all the way at the beginning of the same heights of new infections among black and white MSM. This is transmissions, leaving the community of those living with HIV out into people who are susceptible. So you can actually take the care continuum and see where transmissions come from. And we did some very simple exercises to show that because the denominators are so different, because the white MSM community is so much larger, and we know the size of the we know prevalence, which is this inner box. These are the new numbers of new infections that I was showing on the previous graph. We were able to demonstrate that because prevalence is so high and the community is so much smaller for black MSM, you can actually reconstruct the observed incidence rates in the US just from the care continuum alone. Because we have a large numbers of infections entering communities of different sizes. So this is essentially reverse engineering our surveillance data to demonstrate incidence. And this is really showing the power of the care continuum to actually be influencing incidence, which is a totally non-typical way of thinking about this. We think about HIV prevention usually solely from the HIV negative perspective. But frankly, virus is coming from somewhere. It's coming from people that were failing for care. And so this is showing the reverse way to think about that. We did a number of different exercises, and we showed that even if we can magically fix care in the US by very heroic means, for example, by imparting upon black MSM the care continuum that white MSM experience, or even having very high levels of diagnosis or retention, we're going to only fix incidence by about 27% in the short term. But right now we're in this snowball phase of sorts of the epidemic where prevalence is driving infection probably for quite some time. And I'm actually going to show you exactly how much time, if I can get to it, because we have another model coming up. This is a very simplistic modeling approach with some more cool stuff coming. So I'm just going to put this up here. This is what the workshop is later. I'm going to revisit in the workshop many of the challenges in assessing the individual risk behaviors. So as I showed in the meta-analysis, we showed lower levels of substance use and sexual risk for black MSM. And that is possibly quite true, but we also know that there's a clear history of stigma and biases that would be impacting this community that may actually be impacting reporting. But yet we often just rule out misclassification as just we can't go there, we're not going to think about it. But in the workshop, I'm actually going to show some studies where we were actually able to demonstrate differential reporting by race for completely understandable reasons, but ones that impact our estimation process. And so I'm going to show those results and talk about how they've informed our studies and what we've done to improve on them later. But all this is to say that I wouldn't necessarily assume that the individual level risk behaviors are so much lower for black MSM. They're probably closer to equality, and for some behaviors, possibly higher levels of risk than white MSM. More detail, come back later. So I'm going to show two pieces about biological factors, because I think again, this is an area that's generally under talked about, but there's probably some biological aspects to this race disparity. This is the incidence data for the 5 STIs we looked at alongside HIV. So I've shown the HIV incidence data, but we saw the same disparities for STIs And we saw, all new cases of syphilis were in our black MSM, and we basically had high levels of incidence for everything here. And again, 10% incidence for rectal gonorrhea and chlamydia. So it's the same exact picture. What is going on? We have these essentially co-occurring epidemics. What is going on here? Is there some common underlying social component? Are there common social disparities that are giving rise to all of these pieces? Are there common network features that are driving all of this? Or are there the causal components? These are not necessarily mutually exclusive. Are the STI epidemics facilitating the HIV epidemics? Is it the reverse? And there's there's basic science evidence for both of these pieces, frankly. I'm just going to show some evidence for this one, that co-infection with STIs is amplifying HIV, is rendering men more susceptible to HIV infection. And we use data from the cohort to look at this one here. It's a really challenging problem for people that have thought about this before. We have a very big problem of confounding when we think about rectal STIs, and which I'm going to show specifically our rectal STI analysis, and HIV infection. The reason we can't, uncovering the causal relationship here is really challenging, is that we have what we call behavioral confounding, that the risk behaviors for one are the same as the other, right? So, for example, having unprotected receptive anal intercourse is a very important risk factor for both rectal STIs and HIV. And so if we don't adequately control for the litany of background factors, we really can't understand the causal relationship between rectal STIs and HIV. We'll see an association, but we won't know the causal component. It's actually a much more complicated process. It's usually a very time-dependent process where men have an ongoing pattern of high-risk behavior over time that you need to control for, and then you have an earlier rectal STI that you need to prove leads to later HIV infection. So it's really, it's an epidemiologist's dream or nightmare, I'm not sure which, to untangle this, and it's not very pretty, because you need to basically control for all of these time-dependent confounding processes to really deal with this. Or you conduct an RCT, which is never going to happen in the US for MSM for this, but basically you need to have some really fancy ways to handle this. Oh, that's what I just said. Okay, so ideally we would settle this with some kind of randomized, probably intervention study for STIs for MSM, but to demonstrate the causality of this. Typical regression approaches here really don't work because HIV is typically rare and you can't throw a bunch of stuff in your model. And the STI exposure is generally uncommon too, but in our study it was more common than HIV infection. The confounding is usually time varying. So typical regression approaches are really not well suited to dealing with this. So we used a propensity score weighted model, otherwise known as a marginal structural model, or MSM for MSM for the epi geeks. I think this is the first MSM for MSM. And this was basically an approach where we basically were able to adjust for all the confounding and the time varying components. And basically by basically doing a weighted analysis where we predicted the STI exposure, we had more STI exposures. And so that I don't have in this presentation all of the details. I have a whole hour talk just on this analysis, which we could stay for 4 to 5 o'clock and do. But basically we were able to, by weighting men in our HIV Cox model, we were able to essentially undo as much of the confounding as we could. And what we got here was that we were able to attenuate what was earlier a 3.7-fold hazard ratio into a 2.8 hazard ratio after controlling for a whole lot of stuff that no one had been able to do before in our weighting model. And basically, we found that the causal effect of rectal STIs was probably still quite strong among men who had rectal STIs. So we were able to adjust for a lot of behavioral confounders and remove about a quarter of the naive association between STIs and HIV incidence. So this, again, so the 3.7 was the hazard ratio for men who have rectal STIs for HIV acquisition, and we were able to move it down to about 2.8. This is very similar to what some other studies have done, but no one had really done this in a prospective cohort before. This is usually done in retrospective data from STI clinics. So this was cool to be able to demonstrate it in a prospective design. But
Any of those three major STIs?
this was just rectal gonorrhea or chlamydia combined. We had to harness the data where it was, and that's really where we had the most data to work with. So the population attributable fraction was about 15%. So that would be the merger of this hazard ratio with the frequency at which we saw rectal STIs. So not everyone has a rectal STI. This isn't going to explain everything. And it explained about 15% perhaps of all HIV acquisition in the cohort. There's a whole lot of limitations to this analysis. We only were able to adjust for what we can specify in our modeling. And there's no real network view of this. So I'm gonna put up one slide here on genetic susceptibility, which is something that really has kind of disappeared from the literature. It kind of comes and goes. But for those who are familiar, the CCR5 delta 32 homozygote genotype basically renders you immune from HIV infection. But it's essentially only found in the white non-Hispanic population. What's not really talked about is the heterozygote. So the heterozygote means you have one deletion allele on one copy, and then you have a healthy version of the gene on your other chromosome. And the heterozygote actually confers a fair amount of protection. It confers about 70% protection from HIV infection, at least according to this HPTN vaccine preparedness study paper. And thus here's a 70% protection. And what we see here is basically while the wild type, the double deletion homozygote is essentially only found in white men, but the heterozygote is quite common in white men. So we see about 18% of white men are heterozygotes compared to about 3% of black MSM. So you put that together, and we essentially have about 20% of white MSM have some level of genetic protection actually from HIV infection compared to 3% of white MSM. And I'm actually going to very, very fast, because we're running out of time, show you what this looks like at the population level. So this actually may have serious population level impact. Okay, we have a fifth of white MSM at reduced susceptibility relative to black MSM. So I'm going to show you some results from the MARTIM study, which was done with, really run by Steve Goodrow, who Pamina has done a bunch of great work with, and at a University of Washington. And we essentially synthesized all of our involvement in man data, all of our network, all of our behavioral data, spent like 2 years just parameterizing this model. And it's this extremely robust agent-based model from which we were able to evaluate a lot of our hypotheses. And I want to just show two cool results here. This is the result of how long does that snowball process last. Remember how I showed that, okay, prevalence today is probably explaining a lot of incidence today, and there's the care and all of that. Well, it turns out that on its own is not enough. Okay, it gives you a disparity that converges within 20 years, and this is prevalence among black MSM. This is prevalence among white MSM on the bottom, and the epidemics converge within 20 years. Prevalence is not going to do it forever. But this does show that in the short term, this does explain a lot of the disparity is explainable by where you start in your prevalence. But there is a convergence eventually, because there's actually got to be something else. And I'm going to show you what that something else looks like. We actually probed a lot of different pieces here. And basically, there's a lot of information. These are all of the scenarios in our agent-based model. And where there's a check means that we fit race-specific data for each of those, and where there's a line means we assumed average between black and white men in our model. So this is an agent-based model of black and white men, and this null scenario assumes everybody's the same, and this as-observed scenario fits all of our data that was race-specific, care continuum, CCR5 distribution, sex behaviors, and so forth. And then we were able to isolate the effects of each factor. What is the care continuum alone doing? What is CCR5 doing? And then sexual behaviors that may be reported, that may be affected by stigma, and so forth. So I'm going to just show you these graphs, and then we're basically done because I'm sorry that we're at time. When you set black and white men the same, you see the same exact, you see a null disparity essentially. This is black prevalence over white prevalence, and you get a value of 1. If you fit all of the observed data from both studies, you get a disparity you get black men having about half the prevalence of white men. This is because of the individual level risk behaviors. Black men are actually reporting lower levels of risk in our study, just like every other study. CCR5 delta 32 actually is actually enough to undo, it's enough to go from this null value to about 25% increased prevalence over white men. The care continuum contributes about a 45% increase in prevalence, as well as certain behaviors that we know that, that are influenced by stigma, such as disclosure of HIV status. Sexual behaviors alone, again, yield a very low epidemic for black men compared to white men because of these lower levels of reported risks. Care continuum, differences in care and genetic susceptibility yield a twofold disparity on their own. Okay, so this is the power, these are processes that are essentially out of individual men's control. This is just genetics and care. Okay, so we see that there's actually a lot going on here that's probably just owing to those two factors. The maximum disparity that the model was able to achieve was about a 2.2-fold disparity in prevalence, and we actually in our own study observed about a 3-fold disparity in prevalence. But we're able to show essentially that a lot of observed disparity is probably being driven by care and possibly by CCR5. Now, yes?
And just to clarify, these are modeled or these are actually assessed or recommended?
These are modeled based on the parameters from our study. We then put them to a model to basically simulate a new population. Yeah. Here's another view of those data. This is our observed black prevalence in our study versus our observed white prevalence. And this is the data that essentially I showed at the beginning, showing about a 44% prevalence versus about a 13% prevalence for white men. Here's the confidence intervals. And when we were able to model, we couldn't quite hit either of these pieces. We were able to find disparities. We couldn't quite get the epidemic high enough for black MSM. We were able to make disparities. So for example, here we have a 20% prevalence over 10% prevalence. But what's really interesting here, and this is going to be the focus for our later workshop, is we did a hypothetical model where we basically gave black men the exact same behavioral profile as white men. We didn't give them any more risk, we just gave them the same level of risk behaviors. And we were able to actually exactly hit the observed prevalence for black MSM of 44% in the model. And so I'm going to talk about the impact of underreporting of risk as this part of the second workshop, and show that actually we probably had a bit of that going on. And once we are able to do some hypotheticals to basically undo some of the underreporting of risk, we were actually much more likely to hit the observed prevalence in the model. So misclassification is a real issue. Big shift. And so I'm just going to end here. How do we fix this? We need large improvements in HIV care. The National HIV/AIDS Strategy lays that out pretty well. We need major investments and interventions for testing and treatment, and we need to understand the social determinants of all of this. We also need better measurement of the HIV care continuum in general, and that's something I'm working on pretty actively with CDC. One of my other hats is that the surveillance needs to be markedly improved. We probably need to fundamentally change the equation. We need better biomedical interventions. I don't see how we're not gonna really behavior change our way out of this at the moment alone, that we also need a biomedical component. And so we can lower prevalence or we can lower susceptibility. Those are really our two levers, which many people here know about. And there's some more modeling that we need to do. At least that we're doing, to understand determinants and prioritize solutions. We have a number of modeling studies underway. How do we roll out PrEP? What's the impact of this? What's the best way to achieve that? We have a bunch of different studies underway that really get at some of these pieces. The element studies, what Pamina mentioned, that was our NIDA-funded cohort. We're looking at best ways to roll out PrEP in addition to a whole bunch of other things in that cohort. We have a bunch of modeling studies through our cooperative agreement with CDC. And then we have basically a version of the involvement study just for men living with HIV to understand the determinants of differential achievement of suppression. So have replicated our involvement model essentially in 2 new studies that are each specializing on certain aspects that we identified in the first study. Now I'm done. Sorry, thank you.